Hello everyone. So today I have invited Dr. Dikcha Pandey. She is my good friend and she is a critical care clinical pharmacist in NIMS Hospital in Jaipur, Rajasthan. So I welcome you on my YouTube channel, Dr. Dikcha. So
Thank you so much for having me. Hello,
thank you.
everyone.
Yeah.
Thank you.
So today we are going to discuss about a lot of things. So before we start discussing, I wanted to make an announcement that if anyone is interested to attend our live webinar, that will also be posted on our YouTube channel to catch the errors. So we are also planning to make live webinars on these things. So if you are really interested, you can definitely check out the link in the description of this video. So
Yeah, it's going to
let's
be a lot of fun because every one of you are going to be participating in it live. So it's going to be very fun. So just subscribe to his channel and check out the link.
Thank you. Thank you. So before we start, I would like to ask you some questions like as you are working as an ICU pharmacist, so what are the roles and responsibilities that you do and how it is different from normal pharmacist, which is also looking up into the a lot of things like medication chart review and whatever we study. So how it is different from what we study in a practical scenario.
Okay, actually, this is a really important topic that I wanted to put it in front of everyone. There is actually a huge difference between clinical pharmacist and a pharmacist. First, there is a study course. So mainly a pharmacist who is a pharmacist needs to go through either a diploma in pharmacy or bachelor's in pharmacy or MPharm also. But there's exception for PharmDs. They have to have, clinical pharmacists, they have to have a doctor of pharmacy or masters in pharmacy practice as their degree to officially practice the clinical pharmacy. So yeah, and roles are also quite different. Pharmacists are supposed to, they can choose various paths if, particularly if we are talking about having a pharmacy, medical store, then they actually their first role is to dispense medicine and also patient counseling. Also, they see behind the scenes that if the dispensed medicine is, actually need or if there is any interaction, they do those things behind the counter as well. But clinical pharmacists, what they do is they deal with the real patient at the real time in the real environment and make the change. So both of us are doing our part in medicine safety and improving the patient safety outcomes, but in a different environment, and the methods are a little different.
So that's really nice. So basically, not like it is not a traditional way or traditional approach where pharmacists, always dispense the medicine. So it is beyond that. And
Yeah.
in real world practice, like we deal with patient, we do ward rounds, we do a lot of interventions and to prevent medication errors. We work as a quality performance indicator. So yes. So when we work along with the quality teams, so we try to enhance the quality into the healthcare system to analyze the gap, to rectify the root cause analysis, and to do some CAPAs like corrective action and the preventive actions for the errors if it has happened. But we try to minimize it before it reaches to the
Yeah.
patient. So it is very much important.
We are actually the bridge between the doctors and the real patient outcomes. We are like checkpoint in between them. So that
Yes.
is where our role fall into.
Yes, so it is a multidisciplinary approach where we are bridge between nurse, pharmacists, doctors, and to all the other healthcare workers or the professionals.
Yes.
So I would like to ask you about some questions regarding how do you only work in an ICU care settings or you just take rounds all over the hospital and how like how critical care patients is different from the real uh, from the other patients. So I would like
Yeah.
to ask you, like, if you can, share us something about your based on your experiences.
Yes. So actually, we are six clinical pharmacists in our hospital right now. And the pharmacists are just given ICUs, all six clinical pharmacists, and ICUs are divided. So right now I'm handling medicine ICU 1, 2, 3, and 4. And total patients are approx 46 patients, 46 beds are there. So in ward, I think there is a need of clinical pharmacists in ward as well. But at this point in critical pharmacy, critical setting needs more of the focused kind of clinical perspective than ward, because we find a lot of different patients in ICU in comparison of the world and ward, and the patients are also in very serious condition. And most important thing is they are presented with many comorbidities, and that is where our roles plays into. So we need to check how we can improvise the patient safety and how we improvise the patient safety outcomes by playing our role. So because there is a lot of things that we our roles gets into, like renal dose adjustment, hepatic dose adjustment of antibiotics, or dose adjustment of anti-TB therapy. So that is where our roles get into. So what we do is we go through each of the patient, and of course the patient that is in very clinical need and very are presented with a lot of comorbidity, we go through that patient first. We first check the medical history, the comorbidity, or the symptoms or the complaints that the patient presented with. And then after that, a lot of people think that we run straight to the medication chart or prescription, but that is not it. We need to first have all the details, all the history, all the labs, complaints, everything, symptoms, everything that will help us further, like deciding the medication, deciding the medication that will be most safer or the most effective. So then we go through the chart. So in the chart, we first identify all the medicines. We see if there is any unnecessary medicine or any polypharmacy going on, because we need to reduce the polypharmacy as much as possible, because it also makes the therapy cost effective for the patients, and it can be toxic also. So we need to see if the medication prescribed is actually intended for the complaints or the symptoms or the disease that the patient came in. And then we go through the dosing and then frequency. And we see, after that, we see if the medication is contraindicated, and then drug interaction. So that is how we go through, like layers and layers of making sure that the patient is getting the most effective and safe therapy possible. So that is why I think clinical pharmacists are the most important in critical care than in ward.
Okay, so I would like to add on something, because clinical pharmacist. So as you said about the polypharmacy things, so we also understand about the special populations in the ICU care settings. So special populations can be either pediatric, geriatric, or the pregnant women, or any other some exceptional populations. So these populations, require some dosage adjustment, like not one size fits all. Like it's not necessary to, the same dose will be required for all the same patients. So there are dosage adjustment is required. Like for example, in a geriatric patient, when we consider geriatric in a 75 years of age, in older adults, right? So when geriatric patient, they have declining in the organ functions, right? So when medications, when medications is being administered, let's suppose that oral medicine is being given to them, so there will be a delayed into the absorption, and also it will be delayed in excretion, like a complete
the whole pharmacokinetic
different
and pharmacodynamic
parameters. Yes, so these both things will be different in as compared to the general population. So it is very much important. Like that's where the clinical pharmacist can also plays a role. A lot of things. It's not
We
just
need to
only
pay
for the
specific
one thing. Yeah.
Yeah.
So it's not just
Considering the population, we need to pay specific attention to the different population of according to the needs.
Yes, exactly.
Like those existed in pediatric, geriatric, renal, hepatic, obese patient, diabetic patient, the patient in sepsis or renal function. So we need to, we actually as a clinical pharmacist go through in a detail about what will work for what kind of patients.
Yes, exactly. So I would like to ask you something like, how do you do therapeutic drug monitoring? Like suppose that as we have learned in theoretical, like we used to measure the in the condition of the antibiotics. So in
Yes.
when we take antibiotics, which is which is having a narrow therapeutic index. So when we take the samples, like we used to assess it through crush and trough and okay. So like
Yes.
it's yeah. So it's like in a practical scenario, it's not necessary, or it
Possible.
maybe not
Yes.
possible. So how do
It is
you
time taking
assess?
actually.
Yeah.
Yes, actually, one case I remember, it was of the epilepsy patient, and the patient was resistant to almost all the anti-seizure, anti-epileptic medications. So we were trying out everything because, you know, sometimes we also need to experiment. If that is how we will know, right? The patient is resistant to, or if the drugs are, like working or not. So first we added first line, second line, 2 or 3 medication, but the seizures were not stopping. And then we had added phenytoin actually from day one of the admission, and it's been 7 or 10 days, but it was also not showing any result. So that is when I discussed it with clinical team. What if the patient is actually the case of drug resistant seizures? So we need, if we find the effectiveness of this medication by TTM, by doing TTM, then we might actually find if the level of drug that we need to have in particular system is available or not. If it is not available there for any reason, like any pharmacokinetic steps that the drug might gotten have lost in the body in absorption, distribution, metabolism, anything. So maybe that is why it is not showing effect. So we need to see the TDM. So what we did is we took out the sample 1 hour before the next dose, and then we sent it to the pharmacology lab. So that is how we measured. But it is, like the patient was actually resistant to phenytoin. It was not affecting him at all. So we changed it to another drug. But usually that is not possible because there is unavailability of equipment in the lab. There's timing because we need to do everything at fingertips, everything, like at time. So that also takes time. So usually what I do is if I already know what this drug could cause, there is monitoring parameter of every drug. We already know that. So if I would see that any patient is prescribed with narrow therapeutic index drugs, so I would see what monitoring parameter that drugs needs to go through, and I'll check it just by lab reports. Like some elevates liver enzymes, some elevates AKI. So that is how I see this. I do the therapeutic drug monitoring, and according to it, if I need to decrease the de-escalate the drug, then I discuss this with the clinical team. Also,
Wow.
there is some symptoms we can see, like of digoxin, we can see the yellow sclera around the eyes. So those are the physical symptoms we can see.
Yes. So it's like, like clinical pharmacists have a lot of work in hospital. When, if someone asks that, it's like, what really clinical pharmacists do, like, are they dispensing the medications or is it something different? So that different is what we are doing, right? So
Yes, we
I
actually
wanted,
do a lot of behind the scenes. Actually, people always see us just scrolling through the file of the patient, reading through the medication history, whatever. And what other people would in their perspective, what they would see is like we're just going through the file, but behind the scenes, a lot of things happens that actually make the clinical difference. And I've experienced it a lot of time in my in my time in the ICU.
So, like, how do you start assessing the patient when the patient gets admitted to the ICU?
Yes. Actually, I first go to the ICU, and then I actually already know, I would be already knowing what this patient case is, what the diagnosis would be. So if some patient is, for example, let's see if he is AKI also, if he is CVA, or if it's polytrauma, etc. So my attention goes there first. Before entering the ICU, I would be knowing what cases is there in what beds. So if the cases are of comorbidities, multiple comorbidities, then my attention would go there first. But if I know that the patient is of, like requires equal attention, then I would start with bed number one. I would go to bed number one, and accordingly I go. So yeah, I
So,
just go to or not. We need to see that first.
so as you have mentioned initially about comorbidities, like patient are, they does not come only with one disease. They might be having a multiple disease, right? So they might be having a lot of comorbidities. So to evaluate, to understand, and based on that, we have to do some prescription auditing or the medication chart reviews. And if there is anything related to, if the any medicine that causes any kind of ADRs, so it is also very much important to report ADRs to the Pharmacovigilance Program of India. And now it is very much simple that it is very easy to report ADRs, right? So that's how when I was as a clinical pharmacist, I started doing it from this perspective. And the second thing is to understand, like, if what is the purpose behind of prescribing only this medicine. So that is also very much important to, if you really wanted to learn anything new. So I used to assess like this. So when we talk about the ICU patients, right? So no subjective evidence, right? So
Yeah.
we start directly from the objective evidence, objective
Yes,
assessment.
we directly go through the lab values. We see the complaints, PP, everything we analyze. And then the most important part that I have started, getting excited about, actually interesting part, is antimicrobial stewardship.
Yes.
Yes, after it comes in the fourth step. After checking the medication is intended or not, dosing frequency, medication adherence, any kind of error, contraindication, ADRs, and drug interaction. Then I come to antimicrobial stewardship. So that have excited me a lot because actually escalating, de-escalating plays an important role in patient safety. Yeah, the culture part, because a lot of patients that I have seen these days are resistant to almost all the drugs. So there comes to a point that only one or two antibiotics are left that we need to deal with. So that also would be sometimes nephrotoxic. So we need to see patients' AKI also. So that is where, and I do the calculation part, dosing calculation part. So that is where I think we play the most important role.
So
Sometimes I suggest to the doctors that if the antibiotics needs to be de-escalated because all the parameters, the sepsis are going down, all the parameters are going down, sepsis markers are going down. So sometimes like doctors are also really busy, and they also kind of miss a thing or two. So that is where we come in. We never let anything go missed by the doctors. We are always reminding.
yeah. Yes, yes, I agree. So, I have already made a video on antimicrobial stewardship, how to implement antimicrobial stewardship in hospital with Dr. John Felix. So, if anyone is interested, they can definitely check out the videos into the video sections and they can learn it. So, it's a, yes, good approach towards the antimicrobial stewardship. And So we are going more depth into the clinical part, but let's come up to the surface part. Like this video will be watched by many students, many professionals. So like there is a very much important thing which I wanted to ask you. Like there is a conception between the students. Even when we were a student, we used to have a self-doubt. Like is
Yes,
course which we have taken, is it worth it? Or like most of the time we tell is that
doubt ourselves.
I have done a big mistake taking this course. So would you like to answer?
Yeah. Okay. So when I was in almost, I think second, so I'm a PharmD PP actually. So when I was in second year of B.Pharm only, I had come across this PharmD course, and I was really interested. I never in my life the idea of M.Pharm came into my mind, or MBA or PhD or any sort of things. After I was like hooked in my mind that what I'm gonna do after B.Pharm is PharmD. So, and I started researching about it, everything, like that this course holds. But once I got the admission, I kind of had the reality check. I'm honestly speaking, okay, because I kind of felt like it is quite different than what I had imagined. Uh, Maybe because I was not in particularly in hospital in first year, so I had a lot of questions. But then when I went ahead with the years, first year and second year, and then I came into the internship, then I had a lot of questions in the middle that, yeah, I had those questions that it's the degree I chose is worth it, or did I make a mistake? Even I had that. Not when I started, but in between, maybe because I got really confused in between, because I did not have hospital exposure at first, and it was just theory. So I did not know what actually clinical pharmacists would do. So, but when I got into internship, I actually requested my HOD to give me posting in ICU only during my internship period. And I asked my senior to guide me. That is how like the interest that had almost like died started coming back again. And I know a lot of students go through the same. Even I went to the orientation program. I was called to the orientation program of my college as alumni. And
Yes,
the students there also, yeah, students
I
also
recently
that
came
had
across.
the same question. Yeah.
I recently came across with your post on this student alumni. You were a speaker, you on podium, and you were discussing about
Yeah,
something.
yeah.
Yeah.
So I interacted with the new students there, and they had the same questions. They wanted to do they wanted to do PharmD, but also they had a lot of questions that, like they were still having doubts. And I also would like to highlight an important point here is, a lot of people do it just for the doctor title, and that is very wrong, I feel. Also, it not the students' fault. College also have been marketing it like that way only. This is the second chance to become doctor. And obviously the students would be teenager, 17, 18, 19 years. They would get manipulated.
Yeah.
So yeah, half of the students join PharmD for the doctor title, but actually doctors and clinical pharmacists are very different professions. We work in the multidisciplinary team to make the patient better. It's not like doctors are better, or CPs are better, or CPs are the police of the doctors. Those are the things that, like we need to understand. We are only, both of us are trying equally to make that patient better. Not only both of us, even nurses, microbiologists, everyone have their own roles, right? So I would just like to tell the students that it is just the beginning, and you might be scared saying maths as a subject. You might be questioning why maths, why do I need to study maths here? But it is, so a lot of people actually get quite nervous saying maths in the first year. They would probably thinking that if I didn't choose maths in plus two, then why I'm supposed to study maths here? But actually, it plays quite a huge role when you're practicing clinical pharmacy, because there is going to be a lot of dose calculations. So math is required there. And I don't think any single subject of PharmD is waste, even though I would say that there could be a little improvisation in practicality of clinical pharmacy in our syllabus, but every subject plays a role. And the students also might feel like pharmacology is a lot to remember, dosing, frequency, drugs, names, but it is continuous learning phase. No one actually learns the entire thing in a particular semester or particular exam or something like that. But it is continuous learning thing, because there is a lot of information to grab. There's a lot of chances to forget as well. So there should be a continuous learning process. If once I go through cardiovascular, then I might go through antihypertensive. I might forget cardiovascular, then I need to revise. So that is how it happens. But a student should not think or doubt themselves in that process, because it is not like this. It is always like this, like an ECG rhythm, So yeah, but you will find that everything is making sense once you enter internship. And during internship also, see, I have mentored, I think this is the third, I've mentored 2 batches right now, and this is the third shift posting. Okay, so the 2 girls is under me right now, and the first questions is, what do we need to do here? What are we supposed to do? So after studying for 5 years also, they're still clueless. And that is totally fine. Because internship is when the reality of PharmD starts happening. When you put everything that you have learned in 5 years into practicality. And you actually, if once your intervention changes the clinical outcome, the satisfaction that you would get is something else. So all those years of hard work and all those years of doubting yourself and memorizing medication and forgetting everything, that is gonna pay off, and that is gonna make sense when you start the internship or hospital postings. Yeah, and I think I would see myself in 5 years in the highest post possible of clinical pharmacy, consultant clinical pharmacist. Yeah, that is
That's
where I would
nice.
see myself.
Yeah, that's nice.
Yeah.
So when you
I would
tell,
like to get promoted.
sure. So
Yeah,
when you
and
answer, yeah, yes, please continue.
a lot of people, like they have doubts in a financial perspective of clinical pharmacy as well, that it is not paying good, so I need to change research or pharmacovigilance. But if you're actually interested in clinical pharmacy and actually you are interested in improving patient lives, then I think you should adjust for a year or 2, and the finance is not going to be stagnant where you started. It is going to grow. It is slow, but eventually it is going to grow. But don't do clinical pharmacy if you're not interested. Then you should go to research or vigilance or any academics. But only if you're actually devoted into it, you should choose it.
So when you answer a question like intern ask you about what should I supposed to do here, so it reminds me of like why I should be here. It's like it's completely it happens with the interns that why am I
Yeah.
here? So because
Yeah, actually, they would not have any idea what they're supposed to do, because they actually are fresh out of books, right?
yes.
So in books you study classification, therapeutics, but in hospital, how to put that knowledge in a patient or medication, that is quite hard to comprehend. So the
Yes.
question is actually natural.
Oh my God, chat is here. So we have almost covered each and every part of our discussion. Let's not make it more lengthy. this video might help many of the professionals, not only about the PharmD. So I would like to end this video just by saying that if you can believe in yourself, you can definitely going to achieve anything. So yeah, thank you.
Doubts is just a part of your progress.
Yes.
At the end of the tunnel, there is always a light. That is how I would describe the.
Yes, exactly. Great. So
Thank you
you.
so much for having me. I had a lot of fun.
So it's a great connecting with you, and we'll definitely make some more amazing content together, and we'll also do research together. And thank you.